Hi, I'm Deb White. I'm the Director of Cancer Research and the Deputy Cancer Theme Leader here at SAMRI. I also have roles in the University of Adelaide, so I'm a Professor in Medicine and Paediatrics at the University of Adelaide. We're looking at those patients with really high-risk disease and trying to understand the genomics of their disease and look at the drugs that will best suit each patient. So we know that acute lymphoblastic leukemia sounds like, for the popular press, it's a pretty good diagnosis, but it's the biggest killer of our children in the Western world, aside from accidents and trauma. So it's an area that we really need to work on, and because using the new genomic techniques that we've used, we've managed to identify some of the things that are driving these leukemias. We can now target them with drugs that are already available. So this is a really busy space for us, but a really exciting space, working in the paediatric setting, but also in the adult setting. The new genomic techniques that are around and have come into the forefront of our sort of technology have allowed us to identify genetic alterations within these children that we can target. So there are drugs that we use in other diseases, even like chronic myeloid leukemia. We can use these drugs and target the lesions that we see in these children. So it's really allowing us to take high risk, these are the patients who will do very poorly, and look at treating them in a very targeted way with specific therapies for their specific genetic abnormality. One of the things that's really important about the work that we've done and the assays that we're now setting up is that these children and adults, it's a really poor risk or high risk diagnosis in the adult setting, is that when they present, they look like every other ALL. So there is nothing without a unique screening tools to identify these children as being high risk. So it's only when they fail therapy, and some of them do that very early on, but it's only when they fail therapy that that flag is raised to say, well, hang on a second, why is this child not responding? And as I said, up until now, we've not been able to identify them at diagnosis. Now we can actually start screening patients at diagnosis and therefore get the right therapy to them much quicker than we could previously. So chemotherapy is kind of a blunderbuss, if you like. It targets most dividing cells, but for some patients it doesn't work, and it's not specific. It's been a very good tool, but it's not specific, and we know for some patients it just doesn't work. So we are now moving into the era where we have sufficient tools available to be able to phenotype, if you like, each patient's leukemia or each patient's cancer, if we move to a larger space, and direct the drugs of choice to that specific target. So it really is, and personalised medicine has been a great catchphrase, but it's only now starting to come into fruition. It kind of started in the era of the genomics, of the whole genome projects, screening the whole genome, being able to identify a human genome. But it's now probably 10 years on, just starting to be something that we really believe we can realise.